Case 7. Wound infections. The risks of the hospital setting.
A patient was admitted to hospital following a motor vehicle accident with significant arm and leg wounds. After spending 3 weeks in the ICU, the patient was now running a fever. Wound swab from arm and leg was taken, and blood sample was collected for culture.
Through the wound swab, 3 organisms were obtained from the case study. First organism, Staphylococcus epidermis, gram-positive cocci with gray black staies, naturally found abundant in nature and is part of the normal flora of the skin, and less commonly found in the mucous flora. They have a relative low virulence and can cause infections in patients with low resistance, especially in immunocompromised patients. CNS infections occur in implantation of foreign objects, such as intravenous catheters or bone preface. Repeated CNS in pure culture in mixed culture isolated from the material. Then this confirms the presence of an infection. Organism 2. Pseudomonas aeruginosa gram-native cocci bacillus, widely distributed in nature, isolated from soil, water, plants, and clinical human specimens. It is also found in most man-made environments throughout the world. Because they survive in a moist environment, they can cause problems in a hospital. Pseudomonas found in all types of aqueous solutions, including disinfectants, soap, eye drops, dialysis fluid, zinc, etc. Pseudomonas aeruginosa is the most important pathogens of the genus Pseudomonas. They cause a broad spectrum of infections ranging from superficial skin lesions to sepsis. Infections occur mainly in patients with burns, cystic fibrosis, acute leukemia, organ transplant, otitis externa, and intravenous drug users. They also cause urinary tract, lower respiratory, and eye infections. Organism 3. Acinetobacter baumannii, gram-native Rhodes bacillus. Acinetobacter species are widely distributed in nature, also found in soil, sewage, and water, and also can be found in hospital environment. They are able to survive on moist and dry surfaces, and also can be present in foodstuff and on the healthy human skin. Acinetobacter baumannii is often responsible for hospital-acquired infections. The ability of this microorganism to acquire antimicrobial, multi-resistant, and high capacity for surviving on most environmental surfaces. This has led to increased concern regarding hospital-acquired infections. Infections like respiratory, urinary tract, wound infections, abscesses, and meningitis.
Wound infections, such as those suspected in our case study, can be classified on a spectrum of 5 progressively severe states. 1. Contamination occurs when non-replicating bacteria enter the wound by normal flora bacteria, such as species of Staphylococcus and Streptococcus. 2. Colonization occurs when the bacteria begin to replicating and ahead of the wound site, but do not cause tissue damage. The healing process of the wound is not delayed by the colonization alone. In some cases, colonization can be ahead, enhance the healing process. 3. Local infection and critical colonization occurs when the number of bacteria is greatly increased and begin to overwhelm the host immune system. The wounds do not heal, but tissue invasion has not yet occurred. During this stage, the granulation bed in the wound appear unhealthy. For example, atrophied deep red or gray discoloration with increased discharge, but there is no sign of invasion of surrounding tissue. Delay the healing may be the only clinical sign. 4. Spreading invasive infection occur when the bacteria overwhelm the patient's immune system and begin to invade and damage the surrounding tissue. Signs and symptoms of infection occur, such as erythema, pain, and purulent discharge. 5. Septicemia occurs when the infection spreads through the body via bloodstream and causes systemic symptoms such as fever, chill, and tachycardia. After The infection wound affected pathogenic organisms have invaded into the viral tissue surrounding the wound. Infection of wound trigger the body immune system response, causing inflammation and tissue damage, as well as slowing the healing process. Many infections will be self-contained and resolve on their own, such as scratch on infected hair follicle. Other infection, if left untreated, can become more severe and require medical investigation.
Blood culture contamination is a common occurrence. Up to 50% of all positive blood cultures are false positives due to contamination by coagulase-negative Staphylococcus. As contaminants, coagulase-negative Staphylococcus grow slowly and appear in only one of the culture bottles. Sources of contamination include the patient's skin, the hands of the collector, and contaminated equipment. Appropriate skin disinfection is essential in preventing blood culture contamination.
Now let's walk through the workflow in the lab from receiving patient samples to final identification. On day 0, direct gram stains were performed on the wound swabs taken from the patient's arm and leg. The leg swab revealed 2 organisms, 1 a gram-positive cocci in grape-like clusters, and 2 a gram-negative coccobacillus. The arm swab also revealed 2 organisms, organism 3 a long, thin gram-negative rod, and 4 a gram-positive cocci in grape-like clusters. 6 blood culture bottles were set up to test for bacteremia. For each wound swab, 3 culture plates were set up, 2 horseblood agar, 1 aerobic and 1 anaerobic, and 1 McConkey agar. On day 1, bacteria was found growing in 1 of the 6 blood culture bottles. A gram stain revealed clusters of gram-positive cocci and a culture plate was set up on horseblood agar. Based on the results of culture plates from day 0 and rapid biochemical tests performed on day 1, organisms 1 and 4 were determined to be the same. They were suspected to be Staphylococcus epidermidis, a common microbe found in normal skin flora. A DNase plate and novobiastin disc were set up for confirmatory identification of organisms 1 and 4. Organism 2 was suspected to be Acinetobacter species and an API-20E test was set up. Organism 3 was suspected to be a Pseudomonas species. In this case, an API-20NE test was set up. Antibiotic sensitivity tests were also performed on all organisms. On day 2, final identifications were made. Organisms 1 and 4 were DNase negative, confirming the suspected ID of Staphylococcus epidermidis. The API-20E of organism 2 yielded a final diagnosis of Acinetobacter baumannii, a bacteria increasingly involved in nosocomial infections. C390 resistance and the API-20E-NE of organism 3 gave a final diagnosis of Pseudomonas aeruginosa, also a common bacteria in hospital-acquired infections. It is likely that Staphylococcus epidermidis was present in the wounds as normal skin flora. The bacteria found in the blood culture was most likely contamination due to improper cleansing of the patient prior to blood collection.
Based on the findings of the laboratory testing and as presented in the doctor's report, the primary suspected pathogens are Acinetobacter baumannii and Pseudomonas aeruginosa. Staphylococcus epidermidis was excluded as the causative agent due to its presence in the blood culture, most likely being due to the contamination of the first bottle taken from the patient. This usually occurs due to the improper preparation of the skin prior to blood drawing, where Staphylococcus epidermidis is part of the normal flora. Due to the low amounts of Staph epidermidis cultured from the wound swabs and its consideration as normal flora for the skin, it was also ruled out as the causative agent from the wound sites. Acinetobacter baumannii and Pseudomonas aeruginosa both have similar clinical presentations and are common nosocomial infections in patients that have spent upwards of 1 week in a hospital setting, a statement true of the motor vehicle accident patient, with results in terms of culturing being near identical between the two, with the exception of the location of the wound site in each organism finding. A suitable treatment plan would involve the administration of an antibiotic to the patient that is effective against both pathogens, running on the assumption that either could be causative of patient symptomology. Based on the laboratory and doctor's reports presented in the motor vehicle accident patient, both organisms are susceptible to gentamicin, an aminoglycoside antibiotic that targets the protein synthesis of the bacteria, and imipenem, a beta-lactam antibiotic that targets cell wall synthesis. Due to the susceptibility to both of these organisms to both of these drugs, either drug could be used in the patient's treatment plan. While in this case the treatment plan was simplified due to clearly defined and shared sensitivities between the organisms, this is not always the case. Both Acinetobacter baumannii and Pseudomonas aeruginosa have seen a considerable increase in the development of multi-drug resistance, with both organisms developing mechanisms such as beta-lactamase production, antibiotic efflux, porin alteration, and target site modification. These mechanisms that bacteria have developed to combat antibiotics is not limited to those seen in our case study. An upward trend of antibiotic resistance has been seen in recent years. Both Acinetobacter baumannii and Pseudomonas aeruginosa have been noted to have seen the most significant increase in carbapenem resistance, the family of antibiotics to which imipenem belongs and one of the drugs used as a treatment in our case study. Nosocomial infections, such as those in this case study, find their success in hospital environments due to their ability to develop mechanisms by which to counter our relatively limited selection of drugs. As these organisms evolve, the medical community must find ways to combat their ever-improving nature. To summarize the case study findings, we have attached a lab report that outlines the procedural outcomes from day 0 through to day 2, including final identification. We have also included the doctor's report, which outlines the recommendations to the practitioner so that they may make an informed decision upon what the best treatment for the individual is.